In this video, we are going to continue our series on IV therapy and look at the uses of IV fluids by midwives. These are the learning objectives we'll cover in this video. The reasons behind having or wanting IV access in a patient during labor and birth are primarily twofold. 1. As a means of maintaining maternal hydration. 2. As a means of administering medications, fluid, or blood, recommended as part of the management of multiple emergency situations. Let's start with maternal hydration. Most women can stay hydrated on their own during labor by drinking and sipping fluids. Ideally, this is preferred over using an IV for hydration, as it is less invasive. However, some women simply have a hard time staying hydrated, perhaps because they are nauseous and having a hard time drinking enough, or they are vomiting a lot and are unable to keep any fluids down. In either of these events, an IV running at a maintenance rate of 125 to 250 cc's an hour can help to maintain hydration and, in the case of someone with vomiting or diarrhea, replenish lost electrolytes. A fairly recent study in the hospital with women who had their oral intake restricted found that those who received IV fluids at 250 cc's an hour had shorter labors and required less use of Pitocin to augment labor than those who received 125 cc's an hour. So, if you have a patient who's dehydrated, and yet with encouragement is able to drink a little, you may run your IV at a slower drip, like 125 cc's an hour, than if she is significantly dehydrated, has had a long labor, and is unable to keep anything down, in which case you may run it at 250 cc's an hour. As a rough guide, think in this range of 125 to 250 cc's an hour for maintaining maternal hydration. IVs aside, this study shows us how important hydration is to the functioning of a woman's body in labor. Something to keep in mind as you care for your patients. We need to briefly talk about the type of IV solutions to use. There is disagreement between midwives regarding this. Some textbooks and sources say to use a dextrose solution, such as D5-LR or D5-NS, because they say it will help to give the mother energy. Others argue quite strongly against using dextrose solutions in labor at all, due to the multiple effects the extra dextrose in the bloodstream may have on the mother and the baby after it is born. One of the biggest concerns with dextrose solutions is that the extra sugar goes into the fetal bloodstream, and the baby's body adjusts to the higher sugar levels. After the baby is born and no longer receives that extra sugar, the blood sugar levels can drop significantly, leading to hypoglycemia and significant problems. Factor a few things into your decision on what fluid to use. If you have a patient who can sip on fruit juice, eat some simple foods, or suck on hard candy, then her body can receive the sugar and energy she needs that way, and you should not use a dextrose solution. With most patients, you will find that this is the case, and it is preferable to using a dextrose solution with its potential risks. A simple isotonic solution of lactated Ringer's or normal saline is all you need for hydration. LR, which contains multiple different electrolytes, is preferred if you have a patient who is losing electrolytes through vomiting or diarrhea, over normal saline, which simply contains sodium. On the other hand, if you have someone who has been vomiting a lot, can't keep anything down, and is so dehydrated and exhausted that it is negatively affecting her labor and causing her contractions to be weak and ineffective, then giving something like D5-LR may be beneficial in providing her body with not only fluids to treat the dehydration, but also dextrose to give her body a little more energy and help her contractions be more effective. Weigh the risks with the benefits of a dextrose solution, and if you do decide to give it, be aware that the newborn baby may be at risk for becoming hypoglycemic after birth. Your management should focus on ensuring breastfeeding is established as soon as possible after birth and monitoring the baby for signs of hypoglycemia in the immediate postpartum period. Let's talk now about using IV solutions as a means of administering medications, fluid, or blood. Medications patients may need IV access for in labor or birth primarily include antibiotics and Pitocin. Antibiotics may be given in labor for things like GBS, group beta strep, for women presenting with signs of an infection such as chorioamnionitis, an infection of the membranes and amniotic fluid, or in women who have mitral valve prolapse. Antibiotics may be given prophylactically to these women to help prevent them from acquiring a potentially serious infection in their heart from bacteria introduced into their bloodstream during labor and birth. IV Pitocin can be given to induce labor, augment labor, or to help manage and treat a postpartum hemorrhage. Whether giving things like IV antibiotics or IV Pitocin falls within your scope of practice as a midwife or not will depend on where you practice. In some places, you may be allowed to give them with the help of a consulting doctor. In other places, it may not fall within your scope of practice, and transport of your patients to a hospital may be required for them to receive the medications they need. Let's move on now to talk about situations or emergencies where you may want to administer IV fluids. IV fluids are frequently given to patients who are having abnormal fetal heart tone patterns, such as fetal tachycardia, high heart tones, bradycardia, low heart tones, or a non-reassuring fetal heart tone pattern, such as persistently low decelerations, or repetitive late decelerations. You will study and learn more about these abnormal heart rate patterns later on if you have not already, so don't worry if you are not familiar with them yet. Management of these situations often include, among many other important things, the starting of an IV and the giving of a bolus, an amount of fluid given at a fast rate, of an isotonic solution such as lactated Ringer's or normal saline. This may help to expand the maternal blood volume and lead to improved placental perfusion and improved fetal oxygenation, which may help to stabilize the fetal heart tones. The amount you bolus will vary depending on your patient's status and the type of non-reassuring fetal heart tone pattern. If you have a dehydrated woman and a very non-reassuring pattern, you may bolus 500 to 1000 cc's. If you have a mildly non-reassuring pattern in a well-hydrated woman, then you may bolus around 200 to 300 cc's. And decide to continue or to slow down based on how the fetal heart rate responds to the fluid you give and the other management you've done. One of the most common uses of an IV by midwives is for the administration of fluid with emergencies involving postpartum hemorrhage and hypovolemic shock. In trauma cases involving non-pregnant women who've lost a lot of blood, it is recommended that blood volume be replaced at a ratio of 3 to 1. 3 liters of fluid given for every 1 liter of lost blood. However, in pregnancy, women have an expanded blood volume, 40 to 50% greater than a non-pregnant woman. Because of this, pregnant women have a larger safety margin, meaning more blood can be lost before she will present with signs and symptoms of shock, and less fluid will be required to stabilize her. So, in immediate postpartum women, volume replacement at a 2 to 1 ratio is generally all that is needed. For every 1 liter of lost blood, replace it with 2 liters of fluid. For management of a postpartum hemorrhage, you often want to give fluid fast, so an isotonic solution, such as LR or NS, should be used. Never use any solution containing dextrose, especially when you are giving fluid fast or giving a lot of it. It is recommended that if you have a patient presenting with signs and symptoms of hypovolemic shock, to bolus at least 500 cc's as fast as possible, and then to base further management on how your patient is presenting at that point. You could either continue to bolus another 500 cc's if she is still symptomatic, or you could slow the drip down and give the next 500 cc's and the next IV bottle, if needed, at a slower rate. One thing to note, which we talked briefly about in the last video, is that when we give an isotonic solution to a patient, it will remain in her intravascular space until she becomes stable. But after a few hours, up to 2/3 of it is estimated to move into the interstitial and intracellular spaces. Say we have a patient here with a 1000 cc EBL, estimated blood loss. We give her 1 liter of normal saline within the first hour. As she appears stable after the first liter, we hang the second liter at a slower rate and give it over the next 2 hours. After the second liter is in, we decide that we've replaced enough fluid, the recommended 2-to-1 ratio, and take her IV out. A little bit later, she gets up to go to the bathroom, gets dizzy, and passes out. We have to catch her and lower her to the floor. This is probably because of the movement of a good portion of the solution we gave out of her intravascular space. So keep this in mind and consider keeping an IV in at a slower drip for a longer period of time, or make sure she eats and begins to drink a lot on her own in the postpartum period before you remove an IV. Of course, with any patient who's experienced a postpartum hemorrhage, be careful to monitor them closely in the first few hours, especially when they get up to walk. Make sure that you or someone walks with her and is ready to catch her if she passes out. Keep in mind with a severe hemorrhage where you anticipate your patient will need to be transferred and receive a blood transfusion, a second IV line should be started to aid in the fast replacement of fluids, as well as to have 1 line available to give blood through and 1 available to give fluids through. I think we've covered well the use of IV fluids for hemorrhage, but it is important as well that you as a midwife are able to look ahead and anticipate the risks for postpartum hemorrhage in a patient. There are situations with patients at risk where you may want to consider starting an IV prophylactically during their labor so that it will be readily available for immediate use if needed. Patients you may want to consider starting an IV prophylactically on are those who have 1 or more of the following risk factors for hemorrhage: gravidae 5 or greater, multiple gestation, such as twins or triplets, history of a previous postpartum hemorrhage, prolonged labor, long second stage of labor, the pushing stage, fetal macrosomia, a large baby, polyhydramnios, an excess of amniotic fluid, breech birth, shoulder dystocia, chorioamnionitis, and maternal fever in labor. You may look at this list and wonder, like I once did, how to remember all these risk factors, so I want to point a few things out that I think will help. A number of these have to do with things that stretch the uterus out significantly. An overstretched uterus has a more difficult time shrinking back and contracting down after birth, which is why risks are greater for hemorrhage. A number of these have to do with an exhausted uterus. Any muscle, when it's tired, doesn't function as well, and the uterus is no exception. Long labors or long pushing stages make for a tired uterus, which increases the risks for it to not contract down strongly after birth, leading to hemorrhage. The uterus doesn't contract and function as effectively if the maternal temperature is elevated and her body is fighting off an infection, which is why chorioamnionitis, or something causing a maternal fever, increases risks for hemorrhage. Lastly, breech birth or shoulder dystocia have to do with mechanics. More interventions and manipulation of the uterus may be required to get the baby out. Depending on how fast the baby comes out or doesn't come out, the uterus may actually be physically prevented by the stuck baby from contracting down as it normally would, thus posing risks for hemorrhage. You will study more about postpartum hemorrhage and these risk factors later if you've not already. I just wanted to briefly mention them here. Other emergency situations where the starting of an IV should be included in the management of the complication include bleeding from placental abruption, placental previa, or from suspected uterine rupture. Hemorrhage isn't limited to the postpartum period. Severe preeclampsia, or eclampsia, a patient who is actually having a seizure as a result of preeclampsia. And with cord prolapse to help improve blood flow to the baby and prepare the patient for a possible emergency C-section once you get to the hospital. This concludes this section on the main uses of IVs in midwifery.